Understanding the pathology of Parkinson's disease. Parkinson's disease is characterized by 4 cardinal motor symptoms: tremor at rest, rigidity, bradykinesia, and postural instability, which cause falls and injury in later stages of the disease. This progressive disorder is also associated with cognitive, behavioural, and autonomic impairments, causing increased disability and contributing to a loss of independence. Parkinson's disease is the second most frequent neurodegenerative disorder of aging after Alzheimer's disease. In 2016, it was estimated to affect 6.1 million people worldwide, and according to some estimates, the number of patients with Parkinson's disease is expected to increase exponentially in the coming decades. Generally considered a disease of older age, with a prevalence of around 1% in people 70 to 79 years of age, and nearer 2% in those aged 80 years or more, the disease can sometimes affect young adults as well. The risk of developing the disease is linked to both environmental and genetic factors. The role of alpha-synuclein in the pathogenesis of Parkinson's disease. A hallmark of Parkinson's disease is a buildup of misfolded alpha-synuclein protein aggregates called Lewy bodies. It has been hypothesized that the first alpha-synuclein misfolding may occur in the enteric nervous system, with pathology spreading through gut-brain pathways to the central nervous system, where these aggregates eventually gather within neurons and cause cellular dysfunction and cellular loss. The staging model of Parkinson's disease. The progression of Parkinson's disease has been described with a staging model. During the pre-symptomatic and prodromal stages, Lewy pathology is mainly confined to the lower brainstem, that is, the medulla oblongata, the olfactory tract, and possibly the gut. In the mid-stages, pathology moves into the basal ganglia, nigrostriatal and limbic regions, reaching the neocortex in the more advanced stages. Motor symptomatology and dopamine in Parkinson's disease. Motor dysfunction in Parkinson's disease is thought to arise from alpha-synuclein buildup causing neurodegeneration in the dopaminergic nigrostriatal region of the basal ganglia, and eventual failure of compensatory mechanisms to maintain neurotransmitter activity. Serotonergic, noradrenergic, and glutamatergic dysfunction are also likely linked to motor issues in Parkinson's disease. Here we will focus on the dopaminergic system. The nigrostriatal pathway is modulated by 2 classes of dopamine receptors: the excitatory dopamine D1 direct pathway and the inhibitory dopamine D2 indirect pathway. Neurodegenerative loss of dopamine D1 stimulation leads to downstream inhibition and reduction of voluntary motor activity. In parallel, reduced dopaminergic transmission within the indirect pathway results in reduced inhibition of this inhibitory pathway, thus contributing to reduction of voluntary motor activity. Treatment of motor dysfunction in Parkinson's disease. Drug therapy, largely with the dopamine precursor levodopa, will usually improve motor symptoms in Parkinson's disease. However, issues such as wearing off and other fluctuations in symptom control or drug-induced dyskinesias may arise during long-term therapy. Deep brain stimulation may be used to modulate neural activity in those with troublesome motor complications. Deep brain stimulation may work via local and network-wide electrical and neurochemical effects, modulation of oscillatory activity, or effects on synaptic plasticity, neuroprotection, and neurogenesis. Research is also underway into future therapies that may regenerate or slow down neurodegeneration to slow the disease process.